Hello, everyone. One of the topics which is hardly spoken about is the linkage between chronic illness and suicide. We do not understand how the two are correlated and how one affects the other. Today, we will unpack this with Dr. Lakshmi Vijayakumar, who is the founder of SNEHA, which is a suicide prevention NGO in Chennai. Dr. Lakshmi Vijayakumar, who we are very privileged to have with us, is also the head of Department of Psychiatry at VHS in Chennai. She's a member of WHO's International Network for Suicide Research and Prevention and an honorary associate professor in the University of Melbourne, Australia. She has been conferred honorary fellowship of the Royal College of Psychiatrists in UK for her work on suicide prevention. And she's also awarded the Ringel Service Award by International Association of Suicide Prevention. If you find this discussion triggering, please do reach out to the helpline or other professionals for help. Our objective really is not to scare you, but to make sure that people are better informed. They know how to deal with these scenarios. And you are not surprised when these thoughts occur in either you or your family. So, we will be discussing how this affects both persons living with chronic illnesses as well as their family members. In terms of the audience, do reach out to us if you have any questions on our social media platforms. You can reach us on PatientsEngage or on Facebook, on Twitter, on Instagram, YouTube, LinkedIn, or you can also check out our website, patientsengage.com. Please remember that the views being discussed here are of the physician and are intended only for spreading general awareness, and they do not replace a specific consultation. So please do reach out for help if you are dealing with any complex emotional issues. So let's get started, and we will now talk to Dr. Lakshmi Vijayakumar. Welcome, Dr. Lakshmi, for joining us today, and thank you so much for taking your time. So, we are coming up for Suicide Prevention Day. Wanted to understand, because you do occasionally read and people talk of feeling that they don't want to live, etc. Is there, especially because our audience and our community is largely people with chronic diseases, so is there any additional risk, or is there a evidence that if you live with a chronic illness or if you live with a long-term physical condition, then your risk of suicide can increase?
Absolutely. There is no, it's not any evidence. There is a very strong evidence that physical illness, mental illnesses, any chronic pain, disability, and have very 3 times, 4 times the risk of suicide. So there is just, there are, see, let's classify into physical and psychological, okay? Now, in psychological illness, we know that about 15% of people with depression, 15% of people with alcohol use disorders, and 10% of people with schizophrenia end their lives by suicide. Now, if we take physical illnesses per se, physical illness per se, even in the underreporting of our National Crime Records Bureau in India, about 15% of them die because of physical illness and suicide. Now, typically, if you look at a physical illness, the one thing, the majority of the things have been associated with suicide and depression. For example, nowadays, we know that depression is very much associated with diabetes, and we know how prevalent diabetes is, and depression is a very common factor. I mean, you can name any system, but if we have to go by system, endocrine, if you take diabetes, then people with thyroid issues, they also have a higher suicidal ideas than other people. Then if you take cardiovascular, you have people who have had a myocardial infarction, are more at risk for depression and suicide.
Right.
And if you take neurological conditions, there are so many neurological conditions
Correct.
which are associated, like systemic lupus erythematosus, uh,
Stroke,
multiple
even
sclerosis,
post-stroke,
post-stroke, multiple sclerosis,
brain
and
injuries, traumatic brain injuries.
traumatic brain injuries. The odds of a person having suicidal ideas are 6 times more.
Wow.
We have enough evidence. And forget about all these events in neurology. Even something like people with epilepsy, they have a high risk of suicide. People with epilepsy have a high risk of suicide. And of course, dementia. Now, in dementia, if you look at it, it depends on when the risk is high. See, we'll talk about it when we come to how to prevent it. So the physical illnesses, of course. And then apart from this, there are a lot of other pain conditions. Rheumatoid arthritis, rheumatic pain and all that. And that has been significantly associated with suicide.
Right.
And as you grow older, COPD, people with chronic obstructive pulmonary disease and
heart failure.
Cardiac,
Correct.
So they also have a higher risk of suicide. And why? Sometimes even the medications which are used to treat them have increased suicidal risk. Some of the antihypertensives, some of the drugs which are being used for skin conditions.
Right.
And sometimes some of the chronic conditions, you have to treat them with steroids. And those steroids can trigger depressive episodes and suicidal episodes. So you really cannot separate physical and mental illnesses or physical health or mental health. Right. And so if your physical health is an issue, then the chances of your mental health being affected is high, and suicide is an indicator of your mental health status. So you cannot really differentiate. So you take any systems, any of these physical issues have an impact on
right, on the risk of suicide.
Yeah.
And also, I think repeated hospitalizations and ICU stays, right, are also known to cause. I was reading this book by Dr. Vezeli on called Deep Drawn Breath, and he talks of post ICU PICS, I think it's called. So it's not just delirium, but also apparently it increases the risk of suicide now. So
yes, definitely, because in ICU, the first stage is delirium. But once they come out of the delirium, they go relive the horror of being in ICU. Right. And that is when the risk becomes high. Now, for that matter, even now, if we talk about it, the COVID is not yet behind us.
Correct.
Post-COVID, many people, there is a neuroinflammation.
Yeah.
We have research to show that 33% of people have some kind of a neuropsychological issue after COVID. People who have never had any kind of issues, neurological or psychological issues. 33% of them at the end of 3 months, we have research from multi-site studies, which shows that 33% of them have some neuropsychological issues.
Right.
And majority of it is psychological, anxiety, depression, suicidal thoughts. And of course, many people have suddenly lost their loved ones. Right. So the sudden bereavement has also caused an increase in suicide post-COVID. And basically there is a neuroinflammation during COVID. And so many people now are aware of brain fog. Correct. And many people during brain fog have suicidal thoughts because they are not able to be as efficient as they were before of their cognition before. So they feel that they have reduced in their capacity to function, and that disturbs them. And it actually disturbs people who have been at a higher level of functioning before. Right. Those are the people who are not able to take the lower level of functioning. Right. The other factor, I presume, which also comes at play, especially in an Indian context of largely self-pay as well, right, is the financial burden that a lot of these diseases put on the patient and their family. So one of the refrains we often hear is that, especially
even people with, say, long-term kidney disease and so on, right, is the fact that the financial burden is, and also it leads to loss of jobs and isolation as well. So are these also kind of, again, adding to the risk factors?
Definitely. See, what happens is when you have a chronic disease, which requires a long-term care,
Mm,
right, there is a depletion of finances, human capacity, human empathy,
mm,
and social support. So it is not just one thing which happens. Okay?
right.
So it saps down every facet of support, which makes the person feel very vulnerable. And now we know that, particularly in the above 50s age group,
Mm,
if you start developing a feeling that you are being a burden on others,
right.
then you don't want to be a burden.
Mm,
So it is not that they are against society or anything like that. So this the kind of suicides are not done out of anger,
mm,
but out of a feeling that they're a burden. Okay.
right.
See, whatever be the problem, the feeling of a person who is suicidal is a sense of loneliness,
Mm,
a sense of helplessness,
mm,
and a sense of hopelessness. And
right.
unfortunately, having a chronic disease fits in with all these things. It makes you lonely because, for example, if you have mobility problems, you're not able to move, you're not able
Correct.
to do that. And then you feel you can't control it.
Mm,
It's not like a fracture, there is an end in sight,
and then
so
it's like,
you don't give up hope. But you feel you can't control it, so there's a sense of helplessness. And the fact that you have dealt with it for so many years
mm,
makes you feel hopeless.
right.
And these are the three cardinal feelings of anyone, whether young, middle-aged, old, who dies by suicide. If you ask them, what are the ultimate feelings of a person who's suicidal? It is these: sense of loneliness, helplessness, and hopelessness. And these are acutely exacerbated when you are living with a chronic illness.
Right.
And that is the tragedy of it becomes a double whammy.
Mm. And it, interestingly, the fact that the loneliness, helplessness, and hopelessness doesn't just affect the quote unquote patient or the person with the condition. It often also affects the family caregiver as well. That's one of the things we've also seen. Maybe.
Very true, very true. And that too, how do I say that? Mm, but that too, it becomes more when the condition is uh, something which you know is going to deteriorate over a period of time.
Right, right.
If you have a feeling that this is going to improve over a period of time, then
Mm,
you somehow pull up your socks and fight on. But when you have a feeling like, for example, dementia,
even
or something which
stroke,
is never,
stroke
so
caregivers.
it's not going to improve. Stroke, I wouldn't say is so bad, because following stroke people make some kind of with today's modern medicine, some kind of a partial recovery.
Yeah.
But some definitive thing, like for example, terminal illness
Mm, mm,
or Alzheimer's, things
right,
like that, which you know is going to go from bad to worse.
right,
And that is when it hits you, or
right.
even people with HIV.
Mm, right. So,
And what we have found is
mm,
all these are chronic illnesses. Okay, we know
correct.
that the risk is high. Okay, so how do we
Mm,
identify those who are at risk? It's
exactly.
not that all the people with Alzheimer's or chronic illness are at a risk for suicide. So, how do we identify the people who are likely to be at a higher risk,
Right.
and how do we support them? Is a question.
Correct.
Because there is
Exactly.
no doubt that the association between chronic uh, ill health is associated with suicide is known for over 5 decades.
Mm.
Okay, it is not a
It's not a new discovery or a new.
it's not a new discovery at all. But the very fact that it's a chronic condition, okay, no, you cannot be watchful of a person with a chronic condition for 20 years.
Correct.
It's not possible. So the biggest challenge is in identifying at what stage of the illness or at what period of illness or at what particular triggers they become more vulnerable and provide support. That is the biggest challenge.
So do we have any information on that, or do we have any?
We do. For example, let's take HIV and dementia.
Or dementia, okay.
The maximum risk is within the first 3 months of diagnosis. Okay, so it's very important that at the first 3 months of diagnosis, we provide, and I think the people with AIDS, they have done a really good job.
Correct.
Initially. But that has not percolated to
other conditions.
And there are other conditions. The pre-test counseling, even before you do a HIV test, we have a counseling now to tell them what it is and give them so that they feel supported, right?
Right.
Or that kind of pre-test, for example, Alzheimer's, nobody does.
Yeah.
Nobody does. And that is, so the time of diagnosis is when, even for terminal illness, dementia or HIV, that's the time when they are at a higher risk. For people with epilepsy, majority of the time when they have been reasonably free from seizures for many years, and then they start leading a normal life, and then seizures come, and then they have to stop driving, they have to stop swimming, they have to do this and that or something like that.
Right.
That's when it hits them.
Right.
Because most of the time, epilepsy starts at an early age, so parents start giving medication. They kind of settle down, and then something around the middle age, in the late 20s, late 30s, 40s, some triggers happen, and they have another seizure.
Right.
That's makes them extremely vulnerable at that point of time. For, let's say, for mental health disorders. For a person who has schizophrenia or living with chronic schizophrenia, the risk is high for people who are functioning at a higher level and then have to tamp down their ambitions and all that. And also people who have an early relapse. They become well quickly, they taper down the medication, and then they have a relapse. Those are the people who are at a higher risk. For people with alcohol use disorders, the maximum risk is not in the initial phase of alcoholism or in the late phase of alcoholism. It's usually between the 10 to 12 years of alcohol use disorders, when they lose their social supports, prestige, economy, financial status, whatever it is.
Right.
But for alcoholism, we have a specific trigger. If a person has been using alcohol for 10 years and has had a fight with his wife or partner and the wife leaves him, the risk is highest in the first 2 weeks of a person leaving.
Right.
So like that, we have to find when they are most vulnerable so that we can provide some support.
Right.
For people with degenerative neurological disorders, particularly where the consciousness is high, like ALS,
right,
or MS, then when they have had they're able to pull along, okay, to a reasonable extent.
Right.
And when they feel that they do not have control over their body anymore, that is when the risk is high.
Right. Right.
So if they become incontinent, you know, then
the risk is higher.
So every condition has a
different
time
arc.
period, different
Right.
arc.
And for, you said people with traumatic brain injury, the risk is 6 times higher. Is
Yeah.
there again a point there, or it's not so?
Again, usually we find them, the risk is high in the first 1 to 3 years.
Okay. Okay.
1 to 3 years.
Right.
And for people with terminal illness, we find that people who have both head and neck terminal illness, they are at a higher risk.
When you say head and neck terminal illness,
cancer of
cancer of the
brain, throat, mouth,
right,
neck and head.
right.
They have a much higher risk than compared to people living with cancer of other areas.
So is that because neurologically the brain has more likely got affected? If not,
Not really.
no?
It is a disfigurement.
Disfigurement. Okay. Okay.
It's a disfigurement associated with it.
Yeah, it's the most visible cancer in a sense, right? That's one of the things we realize when we speak to cancer patients, is that there is no hiding somebody who's had a head and neck cancer. So again, is that their personal issue of the stigma they face of somebody with cancer itself, or is it the disfigurement? Especially in an Indian context.
There is no single reason for a suicide. Just know that. There is no single simple explanation for suicide.
Right.
Suicide, there is no suicidal causes which causes suicide. It is due to a variety of reasons. We have biological reasons even, we have psychological reasons, we have social reasons, we have medical reasons, we have religious reasons, we have even philosophical reasons. Right. So there is no single reason why a person commits suicide. But the fact, I always used to say, a lot of things have to go wrong for a person to think of suicide. See, take for any example, somebody living with rheumatoid arthritis. There are hundreds of people living with rheumatoid arthritis who don't think of suicide.
Correct. Exactly.
So what distinguishes them again is not a single factor. It's a multiplicity of factors. The last factor which we may come to know may be the last trigger or the last camel on the horse's back, last hair on the person's back.
Right, right.
Okay? But there is always, it's like an iceberg. What we see at the tip is not really the entire story.
Right, right. So what should, is there anything that the person who's having those kind of thoughts, can they do anything about it, or it's more for other people around them to do?
I think it has to be both. Okay. We know that particularly when it comes to pain, when you actually reduce the pain, a lot of suicidal thoughts goes away.
True. Okay. True.
For example, we have the Dignitas Foundation in Switzerland, which helps in assisted suicide, which allows euthanasia.
Correct.
So
correct.
Many people with terminal illness go to Dignitas in Switzerland so that they will end peacefully. Now, we have done research and we have found that 60% of the people, and it is a very strict procedure.
They do a proper evaluation, right? Right.
Yeah, proper evaluation, treatment, whatever it is, and only that. The research has shown that 60% of the people who have gone to Dignitas and stayed, once their brain threat was reduced, they discharge themselves from Dignitas. Say, okay, I can cope with it. So pain is a very important factor.
Right.
So if we are able to relieve the pain of people, then most of them will try to see how best they can cope with life. That is
Right.
one thing.
Right.
And the other thing uh, is how do I say that? I remember one client whom I was treating for depression, who had very bad rheumatoid arthritis. She had to pay help all the time. She needed a 24/7 help.
Mm.
And when we were chatting, she said, I'm in pain. There are many days when I feel that I should just end it.
Correct.
I have enough medication in my hands now. They've given me for sleep. I can just quietly sleep. And then I tell myself, my family is doing so much for me. If I do like that, it is that I have not acknowledged all what they are doing for me. I
Right.
am being selfish and see, my pain is more than your pain. I know that their pain is also there.
Right.
So it looks, I have not acknowledged their pain. Why, for example, okay, my mother had terminal illness, had head and neck cancer.
Mm.
She was, you could see literally the bone inside.
Right.
So every day, I had to, at one point of time, I had to put rice tube to feed her. She couldn't swallow it. And I
Right.
used to push it for her. She turned around and said, I said, I'm feeling so bad. Hmm? She said, it's okay. I think our karma is balanced.
Mm.
I gave you milk, now you are giving me milk. And see, I left home when I was 16, and at that time you
You don't think about these things, right?
you don't have that great relationship with your mother. Okay, so
True.
I went to hostel, then got married, work, and all that. So actually, the last 2-3 years when she was really sick, and I brought her to live with me, is when I saw her. She was not a very educated woman. She had studied only till 10.
Mm.
But I learned so much from her in those 2 years about grit,
Mm.
about facing things. My admiration for her was so much. See, one day I was just leaving for the hospital. She was, one of the blood vessels broke. There was a gush of blood all over the bed and everywhere. So I had to stop, clean, and.
Mm.
So I had tears in my eyes. So she looked at me and said, why are you worried, Lakshmi? I don't know how to say. I'll say it in Tamil. I don't know how many of your audience is
It's
Tamil
okay.
now.
Yeah, it doesn't matter.
No, I'll say uh, this body has to decay as soon as you're born, someone. Okay. What does it matter how it decays?
Mm.
Why do you cry? And then to the nursing pain person I used to give her fentanyl patch.
Right.
She will remove it. It's
Mm.
because it said it made her feel very drowsy and groggy. And the nurse said, she has given you only for pain. Why don't you pay them? I said, no, have I ever complained of pain? I've not complained of pain. I said, Amma, you must be in pain. Why are you not saying? No, if I get upset, my daughter will get very upset. I don't want to do that. So not once she complained of pain till her death.
Mm.
Not once she said, oh God, what have I come to? I have always said prayers. I have always believed in God. Why is God doing this to me? Not one word of anger against anybody or bitterness, and not one word of complaint. I don't know whether I'll be like that, you know. So there is grace in going through this. So how do we develop that grace?
Right.
Is what we need to understand. So how does a woman who has studied only 10th grade develop this grace, whereas people who are probably doctorates don't have that grace? Okay. So then it becomes to what you believe in, okay, and how you handle stresses.
Right.
Okay. So having a chronic illness is a huge stress for you,
True.
for the family members, and not only psychologically, emotionally, as you say, financially, in every way. Okay. So how we handle is what determines our humanity.
Right.
Right. If you and the family are able to handle this with empathy, care, and concern, that's what life is about.
Right.
So
I
it's
guess in
not.
both examples, at least one of the three factors was not there, right? They were not lonely because the family, they felt that the family was genuinely taking care, and maybe they felt they were a burden, but not overly so. I'm just, kind of linking back to your three, loneliness, helplessness, and
No,
hopelessness.
I wouldn't.
No,
Yeah, maybe family is around, but having an illness makes you lonely, you know.
I know it does. I am not denying that, but maybe
Having an illness makes you very, very, very lonely. It is how you handle that loneliness is what matters.
right.
So when you're sick, for example, during the COVID, I know this loneliness and isolation and quarantine really made people
True.
go really
Yeah,
desperate.
correct.
Yeah.
Right. Yeah. And I think we are still
So
hearing cases of pretty much everybody you speak to talks of how, their parents went through so much of loneliness and isolation. So I think that seems to be like a constant refrain, which we are still hearing
absolutely,
about. So, yeah. So,
absolutely.
I guess the question still is, in terms of how does someone who's dealing with this uh, develop mechanisms, or, as you say, grace to be able to deal with uh, the fallout of the condition.
The, what I tell my clients is, don't let the condition define you as a person.
Right.
You're not a person with Alzheimer's. You're not a person with epilepsy. You're not a person with stroke. You're you, Krishna, Savitri, whoever it is. Okay. This is something which has happened to you.
Right.
So don't define yourself as this kind of a patient. Okay. You have probably lost the ability of this. You have probably lost the ability of that. You have probably lost the ability of that. Okay. So, but that is not you.
That is
You
not,
have a lot
you
of
are
that.
a bigger
You are a
sum
bigger
of the
picture.
whole. Right.
Yeah. So just because one part goes, it doesn't mean the whole thing goes. Okay. So just have that in your mind is what I tell them. The second thing I tell them is, see, as I said, the feelings of loneliness, helplessness, and hopelessness. Okay. So never feel that you're lonely. Okay. Don't think about your health, ill health, your treatment, and all that. Look to doing something for others.
Right.
Having some job to do, something. You may not be able to move because of your stroke, but you sit in the chair and put covers for your grandson's thing, or you teach the milkman's daughter who comes if you don't have any family, or something like that.
Right.
As human beings,
Build that
when we do
connection with
something,
somebody.
no, not only at the connection, when we do something altruistically without expecting anything in return, we feel good about ourselves.
True. True.
Okay? So do some altruistic act, one simple altruistic act every day.
Mm.
You don't have to do it throughout the day. Just one act a
One
day.
act.
Okay. And the third thing is, don't think on things which you cannot do.
Mm.
Focus on things which you can do. And see whether you can do it better and enlarge on that.
Right. Right. And is that the same advice you would give to, I guess it can't be the same. So what is the advice you would give to the primary caregiver?
The primary caregiver, what I need to give is that you have chosen to be the carer. So you can walk away from that if you want to.
Mm,
Okay.
in theory, yes.
Sometimes. Okay. You've
Yeah.
chosen to be the caregiver. Okay. So here you see a person. So sometimes they may be very thankful for what you do. Sometimes because of the illness, they may be difficult. Okay.
Right.
It may be very difficult. See, for example, if you have to change the diaper of an Alzheimer's, okay. So I ask them to think of how many times your mother or father would have changed your nappies.
Mm. Right.
They did it happily, right? So they are like a child now, literally.
Mm.
Okay. So if you have a grandchild, you will happily do this.
Right. Right.
Think of them like a child and do whatever you want to do. And I tell them, whatever you want to do it willingly. If you don't want to do it, don't do it.
Mm.
The biggest problem comes when you do things which you don't want to do and you feel you're forced to do.
True.
That's when the angst and anger and
Anger and
irritation and everything comes in. Okay. So, for example, you don't want to do some particular chore. Find some method of doing that chore so that you don't become angry. So, the more you show your displeasure or anger, their condition is going to get worse. And that
right.
will again impact your mood.
Right.
Okay. The other thing I would say is don't do it 24/7.
Mm.
Give yourself space. We cannot be careless 24/7.
Correct. Correct.
If you're, then you'll burn out.
Yeah.
So don't do that. And many people feel hesitant to ask for help from
Yeah.
others.
Yeah.
But don't worry about it. Ask for example, if things are getting too tough and there you can't afford a nurse or something like that, and you want to step out for something, if somebody, your neighbor is a good person, say, see, I've done everything, just stay with you for 1 hour. I just want to go for a walk
Correct.
and come back. Okay.
Yeah.
So one thing is whatever you want to do it willingly so that that person feels also that he is being loved, cared for, or understood. And that gives you a positive feedback. So it's a positive loop. When you do
Right.
it very unwillingly, with angrily or irritably, it will give a negative loop. So don't
Right.
do that. Try to get somebody to help you to do that. Have some space for yourself. And also, see, many people are unaware of the resources which are available in their
Correct.
community.
Correct.
I think it's very important when you're dealing with a person for you, you are the carer. You have to spend at least 2 days to find out what are all the resources of help which are available in
Yeah.
your community, in your city, or whatever it is. And it is not shameful to use them. People think it is shameful to use. It is
Mm.
not. For
Does not.
example, you have a function at home and you can't look after. So it's not shameful for you to keep your father in a nursing home for 1 day till you handle that.
Correct.
Okay. But people feel ashamed. Oh, people will say I've chased him out or something like that. It is not. So
Mm.
I think you have to acquire a fairly good knowledge about what are the sources of help which are available for you. Okay.
Right.
As I say, you have to make a list of your internal coping mechanisms and the external social support.
Yeah,
And draw a
correct, correct.
match the following and
Yes.
see where it leads you.
Yeah, and increasingly, I think there are, a lot more support groups that are coming up. Not ideal yet, but at least there are more support
Yeah.
groups, both for the person with the condition, in a lot of cases, but also for caregivers. So,
Yeah.
and I think it's again, yes, it seems sometimes that you don't want to be part of groups because it's a mix of, negative and positive news, but sometimes it helps to stay engaged in those so that when you need it, you can, kind of get some help as well. So I think that's another thing. The other thing is, I just want to also, if you want to briefly talk about the role of helplines as well in this respect, just.
So helplines, yes. Particularly when you are dealing with this uh, kind of issues, both the person who has the problem and the carer, there are times, even in the most loving of relationships, there are times when you feel you've had enough, you want to get away, you want to end it all, you need somebody neutral to
Correct.
talk to, somebody who can understand what you're going through without being judgment.
Mm,
And that's why the helplines come in. Okay, we have had many calls calling from carers. It's not that they want to shunt off their parents or anything. It's just that at that point of time they have had enough.
correct.
They,
Correct.
so once they are able to talk through and share, see, emotional, how do you say that? When we are emotionally charged, our ability to think better comes down.
Mm. You're also fatigued, right? So
Yeah.
there's.
So when you have somebody where your emotions are discharged, then you kind of look back, think more rationally, come to decisions more rationally.
Mm,
Okay? And so when you have somebody who's neither judgmental nor accusatory, who's empathetic and understanding, uh, your emotions get discharged.
right.
It's like the pressure cooker releasing the steam.
Mm,
Then you're able to open up and see what's inside and what you can do, things like that. Okay. So helplines play a huge role. And we have many people who have had stroke, who have rheumatoid arthritis, and who are on oxygen calling
mm,
us.
right.
Uh, no. Uh, and it
So
is
the clarification I also want you to give is because the normal assumption is that you only call these helplines if you're feeling, suicidal, right? So, what is.
in fact, I mean, we do say ours is a suicide helpline. So majority of the people who do call us have suicidal thoughts. There's no
Mm,
doubt about that.
right,
Yeah, but it doesn't mean that people who are going through difficulties cannot call us.
right,
They do call us. But
right.
majority of the people who call us have suicidal thoughts because of all these issues.
Mm,
And suicidal thought is there for a lot of us. It
mm,
is about 10% of the population have had suicidal ideas at some point in their life. So it's not a, I mean, it is a human emotion. It's a
right,
human thought. Okay. And it is particularly high among people living with chronic illnesses.
right.
So, uh, eh, uh, and the fact is, many of them have difficulty in voicing that they have suicidal thoughts.
Correct, correct. Because you're not allowed to, right? The moment
You're
you
not
start
allowed to.
voicing, the others
Yeah.
don't know how to
So,
react.
yeah. So you actually, that's why we say that everybody who calls, we ask them, are you feeling suicidal? Because many a time they're not asked.
Mm,
And that becomes another stigma.
mm,
Okay. So to be able to talk about their negative emotions openly without being judged or criticized is an important aspect of helpline.
So on that, just wanting to, because, we do again have people who will write into us or tell us that they don't know how to react when a loved one, could be the patient or the primary caregiver, says, I've had enough, I wish I could die or whatever, right? So what should be the response? Because the normal response for most people is, no, don't talk like this, think positive, etc., right? That's the
The
standard.
normal response is don't talk about it, look at people who are worse than you.
Mm,
Or
correct.
at the most, if you think you're being very sympathetic, you'll say, okay, what do you like? Do you want some ice cream or something? Something like that. Something which will make them feel good or something.
Right.
But the most important feeling is to sit down with them, talk to them, listen to them, understand why they are going through these feelings, and asking them what is it that they can do to help them feel better. So the
Right.
most important thing is not to negate their feelings,
Mm,
but to sit down with them and say, yes, I'm here. Give them the time, give them the space to express their emotion, explore the emotions, and
mm,
see what are all the factors which is pushing them to say. And see if there is one single factor which can make it a little better. Many
right.
a time, a small factor can make things a little better for them.
Right.
And work on that.
Right. Okay. Any final words? I think we've kind of covered a fair amount, and
Uh,
but if you have
my
anything
final
else
thing
you would like
is
to say, yeah.
uh, no, having a chronic illness is extremely difficult, and many people may feel suicidal. But as I said, don't let the chronic illness define you.
Mm,
You are more than the illness, and you have done more in your life than the illness is preventing you from doing. Focus on what you can do, reach out for help, and express your emotions with somebody,
right.
and that will give you a feeling that you can cope with things better.
Okay. Good. Thank you. Thank you so much, Dr. Lakshmi, for taking
Not
the
at all.
time. Let
Not
me
at all.
stop
Not at
the
all.
recording.